Okay, let's jump straight into step 2, neurology decision logic. When you're looking at abnormal movements, your very first step is to sort exactly what you or the examiner are visually observing. We're going to build a rapid diagnostic tree right now based on things like restlessness, flapping, slow writhing, brief irregular movements, sustained contractions, and wild flinging. So if the vignette describes a patient with this deep inner restlessness, like an intense, irresistible urge to just keep moving, you're looking at akathisia. For test day scenarios, you're almost always going to see this triggered by dopamine-blocking drugs, especially neuroleptics or antipsychotics. It's a dose-dependent side effect. Recognizing that subjective urge to pace or constantly shift their legs, that's your absolute key to locking in the diagnosis over other movement disorders. Now, let's contrast asterixis and athetosis, because the clinical distinction here is stark. Asterixis gives you that classic flapping motion of the hands when the patient extends their wrists. And here's the thing, this doesn't point to a structural brain lesion at all. It points you directly to metabolic derangements. Think hepatic encephalopathy, Wilson's disease, or renal failure. Contrast that with athetosis. With athetosis, you're seeing slow, continuous, snake-like writhing movements, especially in the fingers. That presentation localizes your lesion straight to the basal ganglia. What if the clinical vignette describes sudden, brief, purposeless, almost dance-like movements? Well, then you're looking at chorea. Fun fact, the term chorea literally translates to dancing. These are irregular, unintentional muscle contractions that just unpredictably flow from one muscle group to another. It's completely distinct from that slow writhing we just saw with athetosis. You absolutely must link chorea directly to its two most heavily tested associations. First up is Huntington disease. The second is an acute rheumatic fever presentation, specifically Sydenham chorea. If you see those purposeless, non-repetitive, non-rhythmic movements on the exam, these two diagnoses literally have to jump right to the top of your differential. Let's look at the huge difference in both presentation and treatment between dystonia and hemibolismus. Dystonia involves sustained involuntary muscle contractions. Think of a patient presenting with writer's cramp, blepharospasm, or torticollis. If it's a focal disease, like a severe blepharospasm triggered by bright lights, it actually responds incredibly well to targeted botulinum toxin injections. Hemibolism, on the other hand, is violent unilateral flinging. Half the patient's body is literally going ballistic. It's highly specific and localizes to a contralateral subthalamic nucleus lesion, which you'll most often see from a lacunar stroke. Now, for sudden, brief, uncontrolled jerking muscle contractions, you want to think myoclonus. Unlike chorea, these are very sudden, discrete jerks or hiccups. In an exam scenario, you're going to see myoclonus show up in the context of severe metabolic disease, like advanced uremia and chronic kidney disease, or in rapid onset neurodegenerative conditions like Creutzfeldt-Jakob disease. Moving on, assessing the timing of a tremor builds your next rapid diagnostic tree. Figuring out whether a tremor happens during an action, completely at rest, when aiming for a target, or only while standing up is the absolute core of your decision logic here. Let's break down essential versus Parkinson's tremor. Essential tremor is a bilateral action tremor. It's most noticeable in the hands, maybe involves the head, and crucially, it has no other neurologic signs. A classic exam clue is a patient who is self-medicating because the tremor visibly improves with alcohol. You treat this with non-selective beta blockers like propranolol or barbiturates like primidone. In sharp contrast to that, Parkinson's tremor is an asymmetric resting tremor. It's that classic pill-rolling motion that explicitly improves when the patient makes a voluntary, purposeful movement. What about an intention tremor? This is a slow, zigzag motion that steadily gets worse as the hand approaches a target. This points squarely at cerebellar pathology or multiple sclerosis, and it's almost always paired with ataxia or dysmetria. Meanwhile, an orthostatic tremor is isolated strictly to the trunk and the legs. Its defining feature? It occurs solely when the patient stands up. Pay close attention to the sheer volume of sympathetic triggers for an enhanced physiologic tremor. Physiologic tremor is actually the most common cause of action tremor. Normally, it has a super low amplitude and you can't even see it, but it worsens with movement and really spikes with sympathetic activity. Your test questions are going to link this to medications like beta agonists, SSRIs, tricyclic antidepressants, and corticosteroids, or to physiologic states like anxiety, hypoglycemia, withdrawal syndromes, thyrotoxicosis, or liver disease. Okay, watch out for this classic exam trap, the functional or psychogenic tremor. This mimic typically starts abruptly and causes major disability right out of the gate. But it gives itself away on the physical exam because it completely decreases when you distract the patient. Plus, it presents with changeable, inconsistent clinical features that simply don't align with any known anatomic tremor syndromes. You absolutely must separate a benign, lithium-enhanced physiologic tremor from dangerous lithium toxicity. A lithium-enhanced physiologic tremor is typically a fine, symmetric action tremor limited mainly to the hands. It's non-progressive. It can happen just as a standard, everyday side effect. Toxicity, however, presents with an irregular, coarse tremor that involves multiple parts of the body, not just the hands. And true lithium toxicity mandates immediate action. Why? Because on top of that coarse tremor, toxicity adds prominent gastrointestinal symptoms like nausea, vomiting, and diarrhea, along with widespread late neurologic sequelae like ataxia, confusion, and lethargy. If you see those systemic signs alongside a coarse tremor, you're dealing with toxicity. That requires IV hydration or even hemodialysis in severe cases. Let's shift to restless leg syndrome. This is a heavily tested condition known for causing an incredibly uncomfortable urge to move the legs. It specifically worsens at rest or at night, and it's transiently relieved by walking or stretching. You've got to know its secondary risk factors. It's strongly associated with iron deficiency, uremia, pregnancy, diabetes with neuropathy, MS, Parkinson's disease, and medications like antidepressants, antipsychotics, and antiemetics. The Step 2 decision logic here dictates a very strict treatment ladder. Step 1 is non-pharmacologic. Limit caffeine and alcohol, use hot or cold compresses, and get some moderate exercise. Step 2, check the ferritin level. If it's below 75 nanograms per milliliter, you must provide supplemental iron. For mild intermittent symptoms, you can use carbidopa-levodopa as needed. But for frequent, daily symptoms, your preferred medications are alpha-2 delta calcium channel ligands like gabapentin or pregabalin. Note explicitly here that dopamine agonists like pramipexole or ropinirole are no longer preferred. Next up is post-hypoxic myoclonus, which is heavily tested after a cardiac arrest scenario. The decision tree here relies on a strict timeline based entirely on the patient's level of consciousness. If the myoclonus happens within 24 hours while the patient is still unconscious, this is myoclonus status epilepticus, and persistent forms indicate a really poor prognosis. However, if the myoclonus presents days to weeks later after the patient has actually regained consciousness, this is Lance-Adams syndrome. This form is typically focal and gets intensely exacerbated by action. So, what's your next step? Always grab an EEG. This rules out standard seizures and helps differentiate post-hypoxic myoclonus from typical epileptic forms. Once you confirm it, you treat both the acute and chronic forms of this myoclonus with anti-epileptic agents like clonazepam or levetiracetam, along with any necessary supportive care. Finally, let's talk about abnormal gait patterns. These build a foolproof diagnostic map based purely on how the patient walks into the clinic. Being able to visualize these patterns is going to buy you extremely easy points on exam day. The Parkinsonian gait is narrow-based and shuffling. You'll see a severely reduced stride length and a stooped posture. This is visually very distinct from the scissoring gait of spastic myelopathy. In a scissoring gait, the stance is also narrow-based, but there's this prominent weakness in spasticity causing the legs to cross over each other. The toes actually physically scrape the floor as the patient walks. Check out the mechanical waddling of a myopathic gait versus a glued-down magnetic gait. If a patient has limb girdle weakness from a myopathy, you'll see abnormal pelvic tilting leading to a waddling walk. Contrast this with a magnetic gait, where the patient has immense difficulty even initiating steps. It's like their feet are literally magnetically stuck to the floor. This strongly suggests normal pressure hydrocephalus, which, remember, is often accompanied by cognitive impairment and urinary incontinence. If a patient is stumbling or veering strictly to one side, localize this to a vestibular lesion, like Meniere's disease or benign paroxysmal positional vertigo. They will typically veer right toward the affected side. On the flip side, if you see a wide-based, uncoordinated, stumbling and lurching stance, that points directly to cerebellar ataxia. This could be from a cerebellar stroke, drug toxicity, or chronic alcohol abuse. We'll wrap up with sensory ataxia. This gait pattern is wide-based with a highly characteristic high-stepping or stamping motion. Because the patient has lost proprioception from a sensory neuropathy, they literally stamp their feet just to feel the ground. A massive exam clue is that this gait drastically worsens in the dark when they lose visual compensation. If you see a high-stepping gait that gets worse at night, immediately think of dorsal column damage, which is the classic presentation for vitamin B12 deficiency. Keep these distinctions sharp, and you'll easily nail these questions.